A very good afternoon to one and all. I'm Dr. Sidra Ansari, and in today's session, I'm going to talk about local anesthesia. Local anesthetic is nothing but loss of sensation in a circumscribed area of the body caused by depression of excitation of nerve ending or inhibition of conduction process in the peripheral nerve. Now, a desired characteristic of a local anesthetic agent is that it should be non-irritant. It should not cause any permanent alteration in the nerve. It should have low systemic toxicity. It should have effective regardless if it is injected or used tropically. So the efficacy should be the same. It should have short onset of anesthesia but a longer duration of action. It should have sufficient potentity, that is, complete anesthesia should be produced without any harmful complication or use of harmful contra concentration. Free from producing allergic reactions, stable in solution, and readily undergo biotransformation. At the same time, it should be a solution which could be sterilized. Now, let's move on to the physiology of the peripheral nerve. Now, basically, the nerve function by carrying messages from one part of the body to other. Now, these messages are transmitted through electrical potential that is called as impulses. Now, action potential is responsible for the transient membrane depolarization. Now, this membrane depolarization is important to elicit electrical potential. Now, which eventually depend upon increased permeability to sodium ion and delayed increased permeability to potassium ion. And all of this occur only when a chemical, thermal, mechanical or an electrical stimulus is applied. This is just a brief idea regarding the physiology of the peripheral nerve. Let's move on to the electrochemistry that occur in nerve conduction. Okay, at the resting state, the resting membrane potential is negative, that is minus 70 millivolt. Now this negative membrane potential is maintained because of three things. That is the sodium ion which is present outside the cell, the potassium ion present inside the cell, and the chloride ion which is present inside the cell. Now these sodium ion are potassium and chloride are maintained by their electrological balance. When an impulse is applied or any kind of stimulus is applied, there is increase in permeability of the membrane to sodium ion. Now eventually these sodium ions slowly try to enter into the nerve, resulting in slow depolarization. Now this slow depolarization results to a level wherein the action potential, the nerve membrane is minus 50 to minus 60 millivolt. That is, there is decrease in 10 to 15% of the volt. Now this causes release of a threshold potential. Now which causes rapid firing of the sodium ion inside the nerve, resulting in rapid depolarization. Now this rapid depolarization is later on converted to repolarization. Now in repolarization, the potassium channels, the sodium channels are blocked, wherein the potassium moves from inside to outside. And again a resting membrane potential is established. The entire mechanism takes around 1 millisecond, out of which depolarization takes around 0.3 milliseconds and repolarization 0.7 milliseconds. Now let's move on to the local anesthetic composition. Local anesthetic are basically weak bases and they are insoluble in water. So we need to convert it into a soluble salt by adding hydrogen chloride for clinical use. Now they are basically composed of three parts. The aromatic part, which is lipophilic, the intermediate part, which is mainly responsible, either it could be either amide or ester, resulting in two different varieties of the anesthetic. Then the terminal, that is amino acid, which is hydrophilic. Now let's talk about the classification. As I mentioned earlier, the classification of local anesthetic is mainly determined by the chemical structure, that is the intermediate chain, whether it is ester or amide. Okay, now they differ in two main characteristics. One is their ability to induce hypersensitivity reaction and the other is their pharmacokinetics, that is their fate and metabolism. Let's talk about certain physiochemical properties of the local anesthetic. We begin with ionization. Okay, as I mentioned earlier, they are weak base and they exist partly as unionized and partly as ionized form. Okay, now this portion depend upon dissociation constant and pH of the surrounding medium. Okay, now both ionized and unionized form are important to produce local anesthesia. Now this slide shows a diagrammatic representation where B dash stands for, that is represent unionized local anesthetic, whereas BH represent ionized form. The blue is the voltage gated sodium channel, and the ionized anesthetic will, once the anesthetic, now the ionized form is required to enter inside the nerve end. Once it enter inside, it become ionized. Once it become ionized, it affect the sodium gated channel and close the channel. Okay, inhibit the intracellular fluid. Now, the dissociation constant is nothing but the pH at which ionizing and unionized they present at an equilibrium. When the dissociation constant is less, more of the unionized form are present, there is greater lipid solubility. pH is less, more unionized form is present, greater lipid solubility. Okay, pH is more, that is dissociation constant is more ionized form is present, that is slower lipid solubility. So basically you require unionized form to move from the extracellular compartment into the nerve. Alright. Now, amide type of local anesthetic have decreased dissociation constant. That is, they have greater proportion of the drug is present in the lipid soluble unionized form at physiological pH. Now, this produce faster onset of action. For example, lignocaine have 1 to 2 minutes, whereas procaine has 2 to 5 minutes. The lower the dissociation constant, the faster is the onset. Then, the second property is partition coefficient. Now, it is nothing but measure of the relative solubility of an agent in fat and water. Higher the numerical value, that is higher lipid soluble, less water soluble. Now, more the fat solubility means rapid crossing of the lipid barrier of the nerve sheath. So, greater the partition coefficient, the faster is the onset. The third is the protein binding. Now, local anesthetic agent bind with either alpha acid glycoprotein or albumin. When it bind to alpha 1 acid glycoprotein, it has high affinity but low capacity. But when it bind to albumin, there is low affinity but high capacity. Lignocaine has protein binding of around 64%, whereas bupivacaine has 96%. So the duration of action is related to the degree of binding. So the duration of action of lignocaine is only 15 to 45%, which is comparatively less to that of bupivacaine, which is around 6 hours. The fourth property is vasodilatory ability. Local anesthetic possesses a vasodilatory action on the blood vessel except cocaine. It influenced duration of action. Prilocaine is 50% bound to protein, longer duration than lignocaine, which is 64%, since they have no strong vasodilatory effect. So the duration of action of the agent is affected by the vasodilatory ability. So just to sum up the physiochemical property, for rapid onset of action, you need to have a lower dissociation constant value. So more unionized form is available, that is seen in case of amide. Then you should have higher protein, that is partition coefficient, so more lipid solubility is there. And if you want longer duration of action, the anesthetist should have high protein binding and low vasodilatory property. Let's move on to the mode of action of local anesthetic. It basically interferes with the interaction process in the nerve membrane by altering the basic resting potential, by altering the threshold potential and decreasing the rate of depolarization, prolonging the rate of repolarization. Now, the mechanism, the site of action is at the nerve cell membrane. There are two theories which are put forward that will explain the mechanism of action. First is the membrane expansion theory and the other is specific receptor binding theory. Now, membrane expansion theory explains that local anesthetic have lipid solubility. They enter into the membrane and cause permanent change in the sodium channel and causes expansion of the sodium channel, because of which it inhibit conduction, that is, it affect depolarization. Whereas specific receptor theory state that there are specific receptor present of the local anesthetic onto the sodium channel. When these specific receptors get attached to it, the sodium channels are blocked. This shows a diagrammatic representation wherein a voltage gated sodium channel is present where a local receptor get attached to it, and it causes inactivation of the sodium channel and thus block the conduction. Now, faith and metabolism. Now, absorption is depend upon vasodilatory ability of the drug, the volume and concentration with which it is used, the vascularity of the tissue, the route of administration, and the presence of the vasoconstrictor. Now, let's move on to the individual local anesthetic. We begin with the ester type of drug, that is the cocaine. It is the first and the most that is potent local anesthetic agent, rarely used because of its problem of misuse. It is unique in its ability to produce intense vasoconstriction, that is half-life is around 30 minutes. The dosage that is available is topically 4 to 10% solution. Maximum dose that can be used is 1.5 mg per kg, that is around 100 mg, that is maximum you could use. Now the next is procaine. A patient with proven allergy to amide group, you can use procaine. Now, it is used intraarterially or treated arteriospasm, which might occur during intravenous sedation. It has an excellent vasodilatory property. The onset of duration is very short, that is 5 minutes, and a long, that is onset time of 10 minutes. Dosage is, the maximum dose is 6 mg per kg, around 400 mg max you can give. You could either use it with 2% with 1:80,000 epinephrine to increase the efficacy. It is rapidly metabolized by plasma esterase. Now the other ester drug is benzocaine. It is used mainly as a topical agent because of its poor water solubility. It has low toxicity, concentration up to 20% can be used. It basically hydrolyzes rapidly by plasma esterase, produce p-aminobenzoic acid for its low toxicity. Now, metabolism of these ester drugs. As I mentioned earlier, most of them are metabolized in plasma by pseudocholinesterase enzyme and few of them into the liver. Para-aminobenzoic acid is a major metabolite, that is ester, with no anesthetic effect. It is the agent responsible for the ester allergy. Rapid metabolism, that is procaine half-life is 2 minutes. Now let's move on to the amide type of drug. We begin with the most commonly used one is the lignocaine, also termed as lidocaine. It is highly, that is lipophilic. Partition coefficient is around 3, so it's rapidly get absorbed. It basically metabolizes only in the liver and its metabolites are less toxic than the other, okay, with no action. Its half-life is around 90 minutes. The dosage you could use is around 4.4 mg per kg, maximum up to 300 mg. It could be used with 2% plain or you can use it with epinephrine 1:80 dilution. 4 to 10% spray are available, 2% gel and 5% ointment are also available. Now it has rapid onset of action, that is 2 to 3 minutes, and plain have a short duration, that is around 10 minutes. Whereas with epinephrine it has an intermediate duration, that is 45 to 60 minutes. Then the other one is prelocaine. It produces less vasodilation than lignocaine. The rate of clearance is higher. Extrahepatic metabolism take place. Okay, so there is relatively low blood concentration, thus toxicity is less. Now its metabolite is O-toluidine lead to megalloaminoglobinemia. That is, if it is used in a more than 600 mg in adult, that is methemoglobinemia can occur. Now used either as plain 4% or 3% combined with 0.01% international unit per ml of felpressin as a vasoconstrictor. The onset, it has a slower onset around 4 minutes and its duration of action is similar to lignocaine, and dosage you could give 6 mg per kg, maximum up to 400 mg. The third amide type of drug is bupivacaine. It is a longer acting agent, around 6 to 8 hours of action. Its half-life is 160 minutes. It has greater binding capacity to plasma protein and tissue proteins. It metabolizes in liver. It is basically used in oral surgical procedure wherein long-lasting pain control is required. When you require post-operative analgesic effect is also required, in that case you can offer bupivacaine. The dosage that can be used is 1.3 mg per kg, maximum up to 90 mg, or 0.25 to 0.75% with or without adrenaline in a ratio of 1:2 lakh can be used. Now, Let's talk about the metabolism of amide drugs. Now, liver, except prelocaine, which metabolizes into the kidney and lungs, rest all amide get metabolized in the liver. Now, some of the metabolites, local anesthetic and sedative. Some of these metabolites have local anesthetic and sedative property. The normal local anesthetic dose are it get impaired if the liver is impaired. Even a normal dose can be overdose. As the age increases, you need to reduce the dose because the clearance is decreased, biotransformation is decreased. In that case, you need to decrease the dose. Now, let's move on to the vasoconstrictor, which is also an important part of a local anesthetic. Originally, it is added to reduce the systemic uptake in an attempt to prolong the duration of action, to produce profound anesthesia, and to reduce operative bleeding. Now, two type, okay, that is sympathomimetic, naturally occurring you can use, that is adrenaline, or synthetic like felpressin can be used. Now, the mechanism of action of epinephrine is that it interacts with the adrenergic receptors in the vessels. That is alpha 1 and alpha 2 produces vasoconstriction in skin and mucous membrane and act on beta 2 that stimulate causing vasodilation in the skeletal muscle. Now, metabolism, it appears very rapid in the systematic circulation. The dosage is 1:80,000 is the commonly used one. Its side effect, it affect the heart, blood vessels, hemostasis, lung and wound healing. Okay, basically in the heart, it causes a force of contraction will increase and heart rate will increase. The blood vessels, the BP will initially fall and then rise. Hemostasis basically is help in proper regulating hemostasis, vasodilatory effect on the lung, and it accelerate wound healing. Now, felpressin. Analogous to the naturally occurring vasopressin, it binds to the vasopressin V1 receptor in the vascular smooth muscles, producing vasoconstriction and reduce local blood flow. Now, less potent than catecholamines, poor control of bleeding occur during the operative procedure. Now, it acts on the venous side rather than the arterial side. Now, the dose that you can use this is 0.03 international unit per ml, that is around 0.54 microgram per ml. Now, a constitution of a local anesthetic solution with adrenaline in the ratio 1:80. The basic constitution is depicted in this chart, wherein lignocaine hydrochloride 2% is used, adrenaline in a ratio of 1:80. Sodium bisulfate is actually a preservative of the adrenaline that is used because it undergo oxidation. To prevent oxidation, you need to add preservative like sodium bisulfate. Now, thymol, that is chlorbutyl ringer lactate solution, and water for injection. Let's move on to the local anesthetic technique. We're all aware is maxilla is supplied by the maxillary nerve, which is the V2 division of trigeminal nerve, and mandible is supplied by the mandibular nerve, which is V3 division of the trigeminal nerve. Now, let's begin with the technique of the maxillary nerve blocks. We begin with infraorbital nerve block. Now, infraorbital nerve block, here you could approach by two methods, by canine approach or central incisor approach. Now, in both the cases, you will prep the patient properly, apply betadine extraorally into the infraorbital area, scrub the face. With your index finger, you will try to palpate the infraorbital rim, and just below to the infraorbital rim, you will feel a dip, that is wherein there is presence of infraorbital foramen. So you put your index finger on that and then put the thumb in the vestibule. You will try to raise the mucobuccal, that is lip and the vestibule. And then when you're using a canine approach, you will direct your needle from the canine, bisecting the canine at the mucogingival junction, and then you will inject superiorly and hit the bone. You will keep your index finger on the skin to prevent the needle from coming to the surface of the skin. Okay, you will hit the bone, aspirate, and then inject the required amount of the local anesthetic. In case of a central incisor approach, you will bisect the central incisor from mesially to distally, and then you will move superiorly at an angle of 45 degree and hit the bone, and then give your proper infiltration. Now, the second is So basically, the infraorbital nerve block causes anesthesia of the anterior part of central incisor. Now it causes anesthesia of the lateral part of the nose, lower eyelid and the upper lip of one side. Then here you can ask subjective symptoms to the patient as well as the objective symptoms. Okay, but when you want to extract teeth in the upper quadrant along with the infraorbital, you have to give either palatal infiltration or you could give an incisive block. Okay, let's move on to the posterior superior alveolar nerve block. Now these are basically used to anesthetize the maxillary posterior teeth. Now posterior superior alveolar nerve block is done. In this case, you will direct the needle in the mucogingival fold just distal to the second maxillary molar. Your needle angulation is 45 degree, moving superiorly, medially and outward. Okay, so upwards, superiorly, posteriorly and medially at an angle of 45 degree. Okay, here you will not be able to hit anything. Okay, here at least 2/3 of the needle is inserted, aspirate and then inject. Whenever you're giving any injection, aspiration plays a very important role. Okay, if your first aspiration is negative, that means you are close to the vascular. Just try to change the angulation, just bevel of the needle so that you are out of the vessel and then aspirate again. If your second aspiration is negative, then you are not in the vessel, so you can inject again. If your second aspiration again is coming positive, then you need to change your hub and then redirect the injection. Okay. Now, in case of the anesthesia of the posterior molars, along with PSA, you have to give a greater palatine nerve block. Now, greater palatine nerve block anesthetize the palatal mucosa as well as the palatal root of the molars and premolars. Now, here in this slide shows two photographs. The first photograph depicts the incisive nerve block, wherein the incisive canal, the needle is inserted. It's very painful. A lot of resistance is felt once you are giving, and once you have injected sufficient amount of tissue, you can see the blanching. Once the blanching is seen, that means your block has been injected into the canal. Now, once you have done the incisive canal block, it will anesthetize the palatal mucosa in the anterior region from the central incisor canine to the premolar region, first canine region. Then in case of the posterior teeth, that is posterior to canine, when you want to anesthetize the palatal mucosa and the palatal root, you have to give a greater palatine nerve block, which is given 5 millimeter away from the gingival margin, okay, just distal to the second molar. Now let's move on to the injection technique of the mandible. The most commonly used one is the inferior alveolar nerve block. Now, inferior alveolar nerve block anesthetizes the half part of the mandible. Okay, that is the molar. It anesthetizes the molars, premolars, and the lingual mucosa and the buccal mucosa. It does not anesthetize the canine central incisors. Okay, canine and central incisors, you have to give an infiltration. Now, in this case of inferior alveolar nerve block, you will start from the opposite quadrant. In the premolar opposite quadrant, in the premolar molar region, you will direct your needle towards the pterygomandibular raphe. You basically have to inject into the pterygomandibular raphe space. Okay, once you palpate the raphe, try to retract the raphe. You will feel the coronoid notch and the anterior border of the ramus with your thumb. At the same time, keep your index finger or all your finger at the posterior border of the mandible, so you could assess the angulation of the mandible, because ramus is attached to the mandible at an angulation and it will flare. As the age advances, the flare increase. As the age decreases, the flare increase. So you need to palpate the anterior border as well as the posterior border so that you do not go too posterior into the parotid gland. So you start from the opposite quadrant, premolar molar region, try to bisect. Okay, just around 5 to 6 millimeter above the occlusal plane of the molars, you will feel the pterygomandibular raphe notch. Above that, you inject, hit the bone. Okay, remove the needle, aspirate and inject. Around, you can say you could inject around 1 ml or 1.5 ml. Then, keeping the needle in the same position, you move towards the quadrant where you want to anesthetize the tooth. Okay, and you will inject for the long buccal nerve. As you are injecting, you will try to remove the needle. So, as the lingual nerve enter into the floor of the mouth, you will anesthetize the lingual nerve. Once you have done this, you have to anesthetize the buccal mucosa also. That you have to do by giving long buccal nerve block. Alright. Now this is the way you will complete your inferior alveolar nerve block by the direct technique. Now this will anesthetize the posterior teeth. This will anesthetize the lingual, the tip of the tongue, half part of the tongue, okay, and the lower lips. All the incisors, central incisor, canine, premolar, because you're anesthetizing the entire inferior alveolar nerve branch. Now mental nerve block. Mental nerve block are given basically when you want to operate in the anterior area or you want to do extraction of the premolar canine region. Now keep this in mind that the mental foramen open in the backward direction. So when you are injecting, you will not injecting from anterior to posterior, but you will inject from posterior to anterior so that you are into the foramen as seen in the photograph. This will anesthetize the anterior teeth, that is the central incisor and the canine. But when you want to remove, you have to give a lingual nerve block along with this or lingual infiltration. Let's move on to the Gowgate mandibular nerve block. Now this nerve block anesthetizes the entire nerve trunk. You need not have to give separately lingual block, long buccal block or nothing. Just one block and it will suffice everything. It will directly anesthetize the entire mandibular trunk before it enters into the inferior alveolar foramen. Right? In this case, the anatomical landmark that you need to know is you need to make an imaginary line from the tragus to the corner of the mouth. And you have to be parallel to this line. If you are going to anesthetize the left quadrant, you have to stand on the right side of the patient and your needle should project from the right quadrant and go towards the left quadrant from the premolar molar area. Okay, tell the patient to open as wide as possible. Keep your thumb inside the anterior coronoid process, anterior border of the ramus, and the other finger onto the external auditory canal. When the patient is opening wide, you could see the condyle opening up, that is descending down little bit. Once you see that, you inject from the opposite side. Go medial, go medial, it will be, you will bisect the palatal cusp of the maxillary tooth and you will inject on the medial surface of the mandible. That will be, you will hit the neck of the condyle, aspirate and inject. It will completely anesthetize the mandibular nerve. The other technique is Vazirani achinosis technique. It is a closed mouth technique. It is basically done in case where the mouth opening is limited, wherein there is trismus. Now trismus could be because of infection or because of oral submucous fibrosis or because of trauma or any damn thing it could be. Now in these cases the patient is not able to open the mouth. So how will you give inferior alveolar nerve block? You could use this technique. In this technique you will tell the patient to close the mouth completely. Okay. So from where, if you're anesthetizing the left side, you will take your needle and keep it parallel to the occlusal plane of the maxillary molar and you will inject just distal to the second molar into the mucosa. While doing this, you are on the medial aspect of the ramus, just above the inferior alveolar foramen. You aspirate and inject. You will insert around 2/3 of the needle, aspirate and inject, deposit your solution. And you will anesthetize the entire mandibular nerve trunk. Now, let's move on to the complication of local anesthetic. Now, complication can arise from the drug or chemical used for the local anesthetic, that is, soft tissue injury can occur, sloughing of the tissue can occur. Now, there could also be breakage of the anesthetic cartridge, breakage of the needle stick injury, hematoma formation, or failure to obtain the local anesthesia. Now, the other local complication that can arise is pain and burn on injection. There could be trismus. Trismus can be basically because of hematoma that has formed, because you might have punctured a vessel which result in hematoma in the muscle and trismus will develop. This more commonly occur in PSC nerve block, that is posterior superior alveolar nerve block, because the pterygoid plexus is very close to it. Now the next is edema can occur. If you not put your bevel in proper position and give multiple injection, and edema can occur. Then facial nerve paralysis or paresthesia can occur. Now this mainly occur when you are giving inferior alveolar nerve block, wherein you have inserted the needle far posterior, you have not hit the bone. In fact, you are inside the parotid gland and you have injected. It's a transient condition, wherein the condition will become normal once the effect of anesthesia subsides. In facial paralysis, the muscles of facial expressions are affected. The patient will not be able to close the eye on the affected side. There will be drooling of saliva. The patient will not be able to smile from the affected side because the facial expression muscles are affected. But this is transient. You need to reassure the condition to the patient that this condition will subside once the effect of the anesthesia decreases. Then move on to the systemic complication of the anesthesia, that is allergic reaction can occur, anaphylactic reaction can occur, and toxicity can occur. Basically, toxicity can occur when the patient liver is compromised because most of the time the biotransformation take place in the liver. If they are compromised, toxicity can occur. So these are the systemic and local complication of the anesthesia. With this, I would like to conclude by saying that we as a dentist should make our utmost best attempt to provide the patient with pain-free dental procedures by keeping us updated with all the newer techniques and advancement in the medicine that has taken place, wherein more newer drugs are used which will help us, drugs and techniques are there which will help us to provide more pain-free dental procedures. Thank you.